Hello, good afternoon, everybody. Here I'm Dr. Debasish Biswas, gynecologist from Lalbagh Subdivision Hospital. Here we attended to discuss regarding the different causes as well as the modalities of the prevention of stomach discomfort and the cause of the stomach discomfort and the ultimate treatment of stomach discomfort. Actually, we know everybody that there are multiple causes of stomach discomfort. First of all, if multiple patient, if actually the patient when used to take the drug from over the counter, usually they take the NSAID or steroid as well as the antibiotic that can cause the harmful effect to the stomach that causes irritation to the stomach mucosal lining. And among the antibiotics, especially the amoxicillin, erythromycin, tetracycline, doxycycline, these antibiotics is the main causes of stomach discomfort as well as the gastric irritation. And there are other drugs that we gynecologists usually use, especially in every patient in pregnancy, the iron, that is a ferrous sulfate. This ferrous sulfate is also causes the stomach discomfort, but we're bound to prescribe this iron tablet, the ferrous sulfate, and we have to be more cautious to prescribe this drug, especially if the patient is having previous history of acute gastritis as well as the previous history of gastric ulcer, and if there is any history of previous operation for the gastric perforation. And also this antibiotic causes the antibiotic that we used in our prescription altered the gut flora, and that can causes the stomach bloating as well as the discomfort, and sometimes the patient presented in our chamber of the hospital with antibiotic induced diarrhea. And on that cases, we can advise the patient for prevention of this stomach discomfort by advising. We can advise the patient for prevention of the stomach discomfort to advise the patient to take the medication with the food or the water. That food or the water that can act as a buffer to the stomach lining, and will ask the patient to avoid the alcohol if the patient is alcoholic. And sometimes we can prescribe to the patient the enteric coated tablet that can bypasses through the stomach lining. That also we can advise. Also, we can adjust the dose as well as the timing of the medication and the form of the medication. Sometimes the patient may develop the stomach discomfort with the tablet. On that cases, we can advise the patient to take the syrup form, or if the patient develops the stomach discomfort with the syrup form, then we can switch over to tablet form. And sometimes if the patient is on medication for the long time, single medication, if the patient used to take single medication for the long time, on that cases, if the patient develops a gastric upset or the gastric irritation with that medication, then we have to be more cautious to alter that medication to another one that can cause a little harm to the stomach. Next, we'll come to the point of the management of stomach discomfort. Usually, we prescribe the H2 blocker, ranitidine, famotidine, and samotidine is not used nowadays. And if the H2 blocker is not acts properly, or sometimes if H2 blocker not, if we do not prescribe at first line of the treatment, we can use the PPI. PPI, there is a proton pump inhibitor, omeprazole, rabeprazole, esomeprazole, and that becomes the customized to the doctor, and because customized to the doctor, and doctor is the best judge which one he or she will prescribe to the patient. And along with this, will advise the patient to take the ginger, peppermint for prevention of gastric upset, and we'll ask the patient not lie down after taking the meal, and at least wait for 30 minutes, walk for 30 minutes after taking the food. That can also relieve the stomach upset. And if the patient takes antibiotic and develops antibiotic-induced diarrhea or bloating, patient develops the bloating. On that cases, we can ask the patient to take the pre-probiotics that can develop the good bacteria and the intestine. That also prevent the gastric upset. And this is all of the management portion, but we have to be more cautious when the patient attend to our chamber or the hospital, because actually in gastric upset patient, the patient with acute gastritis may overlap with the gastric upset. Sometimes the patient comes in our chamber with a history of severe excruciating abdominal pain, sharp pain associated with the blood stool, and coughing ground color, vomiting with the blood, that is a hemoptysis. On that cases, we will suspect there is acute gastritis ulcer, formation of the ulcer, that is a peptic ulcer or the duodenal ulcer. And that ulcer in serious condition can develop into peptic perforation. So when the patient come at our chamber, we have to take the proper history from the patient, whether the patient is suffering from the acute gastritis or there is any grave sign or there is a red sign to the patient. On that cases, if there is development of the grave sign, then we'll admit the patient in the hospital and will offer the patient for upper GI endoscopy. And after upper GI endoscopy as well as the rapid urine test for exclusion of the H. pylori bacteria infestation in the stomach lining mucosa. On that cases, not only PPI, will add multiple drugs with the PPI for treatment of the H. pylori infection. That is more common. That is the most common in our country, especially. And also, we'll be more cautious. So we'll take the history from the patient. Is there any history of allergic reaction to any medication? That is the H2 blocker or the PPI. On that cases, we'll avoid that drugs and we'll switch over to another drug. Also, we'll take history of weight loss, chronic weight loss, and cachectic patient. There is chances of any GIST, gastrointestinal stromal tumor, or any CA stomach on that cases. Because in that cases, the patient may also present with GI symptom, gastric upset, and the irritation. This is the small brief for the today. Ultimately, the PPI inhibitor or the H2 blocker, the best judge is and will advise with the patient and the patient party not to take the over-the-counter drugs. And sometimes we get the patient with chronic medication of steroid or the aspirin, especially the heart disease patient or the patient of severe with infarction. On that cases, the patient needs to take the aspirin for the long duration, for the lifelong. On that cases, also will advise the PPI for lifelong. And in pregnancy also, in recurrent pregnancy losses, or there is an Aplas syndrome, antiphospholipid antibody syndrome, we used to prescribe the aspirin. And aspirin on that cases, we also co-prescribe the PPI for the whole pregnancy. Next, yes, there is controversy regarding the use of H2 blocker or the PPI blocker. Which one will be the best for the patient? The H2 blocker, in H2 blocker, some doctors prefer to prescribe the H2 blocker first, and if the H2 blocker doesn't work there, then they switch over to PPI. But there are another group of doctors who first line of prescription was to prescribe the PPI first modalities, but the doctor is the best judge. Krishnan, you can end here, okay?